Welcome to Medico Importance Simplified. So today we are going to study a very important topic which is rheumatoid arthritis. It is a very frequently asked question in orthopedics also. So rheumatoid arthritis, if you see, women are especially elder women, okay? Elderly women are around 6 times more affected, 6 times more commonly affected as compared to younger one. Okay, so elderly women is a risk factor. So in rheumatoid arthritis, there is going to be a symmetrical involvement of the peripheral joints. So there is a symmetrical involvement of the peripheral joints. So there is a lot of associations with rheumatoid arthritis like Felty's syndrome, osteoporosis, and large B cell lymphoma. These all can be conditions that are associated with rheumatoid arthritis. Now, first, if you look at the joint that is involved in rheumatoid arthritis can affect any kind of diarthrodial joint. What do you mean by diarthrodial joint? So, diarthrodial joint. So, what is the meaning of diarthrodial joint? So, any synovial joint, okay, which is freely movable. A freely movable joint is otherwise known as diarthrodial joint. So, just rheumatoid arthritis, in this disease, any kind of diarthrodial joint or a synovial joint or a movable joint can be affected and leading to a symmetrical arthritis. Remember, this disease is symmetrical, okay, it's always symmetrical. Now the commonly involved joints, if you look at the commonly involved joints, especially according to the 1987 criteria, it's going to be wrist joint, and metacarpophalangeal joint, proximal interphalangeal joint, the elbow, the knee, the ankle, as well as the metatarsophalangeal joint. So all of these are very commonly involved joints in rheumatoid arthritis. Very less commonly, the upper cervical spine is also affected. So the upper cervical spine is less commonly affected. These are all most commonly affected. Less commonly, it is going to be the upper cervical spine. Now, remember a very important key point and a favorite MCQ always ask. Usually, the distal interphalangeal joint, okay, the DIP, distal interphalangeal joint are not involved in rheumatoid arthritis, and therefore it is not used for diagnosis at all. And there are very favorite deformities that can occur. We'll be studying in detail like the swan neck deformity, the bottom-ear deformity. So many deformities are there. Now if you look at some deformities, so let's move on to certain deformities in rheumatoid arthritis. So yeah, what are the deformities seen in rheumatoid arthritis? So the first more common deformity is known as the bottom-ear deformity. What is it? The bottom-ear deformity. The bottom-ear deformity. So what is this bottom-ear deformity is? There is going to be a flexion of the interphalangeal joint. The proximal interphalangeal joint. See, there is going to be flexion of the proximal interphalangeal joint, and there is going to be hyperextension or extension of the distal interphalangeal joint. So how will the deformity actually look like? So I'm drawing this finger over here. So if you look at this, what is going to occur? So if you look at, this is your uh, distal interphalangeal joint and this is your proximal interphalangeal joint. Okay, so what is going to happen is the proximal interphalangeal joint will be flexed like this, and there is going to be hyperextension of the distal interphalangeal joint. Basically, in the middle of the finger, there is going to be a depression, okay, formed, and this is known as botanier deformity. So flexion of the proximal, this is the flexion of the proximal interphalangeal joint, and there's going to be extension of the distal interphalangeal joint. So this deformity is known as the botanier deformity. Okay. Now moving on to the next favorite deformity. The first one is botanier deformity. The next one is going to be your swan neck deformity. Swan neck deformity. So this swan neck deformity is exactly opposite to the botanier deformity. So what is it? There is going to be flexion of the distal interphalangeal joint. So distal interphalangeal joint, there is going to be flexion and there is going to be extension, hyperextension of the proximal interphalangeal joint. Exactly the opposite. Okay, these both deformities are exactly the opposite. Botanier deformity and swan neck deformity are exactly the opposite. So how will this picture look like? So swan neck deformity, there is going to be flexion of the distal interphalangeal joint. So it's going to be like this, like a swan neck. Okay, so this is your distal interphalangeal joint which is in flexion, and there is going to be hyperextension of the proximal interphalangeal joint. So there is going to be hyperextension. Okay, this is hyperextension. So this was flexion, like this was flexion, and now this is hyperextension of the distal interphalangeal joint. Sorry, this is your proximal. So hyperextension of the proximal interphalangeal joint. So this is your swan neck deformity. So the next important deformity is very famously asked question, windswept deformity. So what is this windswept deformity? The classical windswept deformity is generally seen in rickets. Okay, so classically it's going to be seen in rickets, but whereas in case of toes, windswept deformity of hands and toes are generally seen in rheumatoid arthritis. Okay, so it's seen in rheumatoid arthritis. So what is this windswept defect is? So one foot is going to be in valgus. One foot is going to be in valgus and another foot is going to be in varus, such that everything will be in looking like like a wind is going to be moving everything in one direction. That's how it's going to be looking. So that's why it's known as windswept deformity. If I have to draw this figure, it's going to be like this. So one side of the leg is on genu valgum and one side of the leg is genu varum. This is known as windswept deformity. So they say that windswept deformity, classically rickets is going to be knee, and in case of toes and hands, if there is windswept deformity, it's going to be seen in rheumatoid arthritis. So remember that this botanier deformity is, there is going to be a rupture of extensor tendon. So there is rupture of extensor tendon in botanier deformity, and initially the joints will be mobile, followed which there will be a rigidity. So now let's move on to the classification criteria for rheumatoid arthritis. So there is a classification criteria of rheumatoid arthritis, and the total score that is going to be given here is 10. and a score of say more than 6 will be indicating rheumatoid arthritis. So first is, you need to first the criteria. So in the classification, the first one is going to be the joint involvement. So we need to check which joints are all involved. So it goes like this. One large joint, say a shoulder, elbow, hip, or knee, or ankle, then the score is going to be 0. If there's 2 to 10 large joints, then the score will be 1. If there is 1 to 3 small joints, say metacarpophalangeal joints or proximal interphalangeal joints, wrist joints, the score will be 2. 4 to 10 small joints, the score will be 3. And more than 10 joints and at least one small joint, the score will be 5. So in joint involvement, mainly you need to see for small joints such as the metacarpophalangeal joint, proximal interphalangeal joint, metatarsophalangeal joint, the wrist joints. These are all small joints, and these joints, if more than 10, is a very strong score, around 5. Okay. Next, you'll be looking on to the serology. So in serology, so you have something known as RF, which is the rheumatoid factor. RF stands for the rheumatoid factor. So when there is a negative rheumatoid factor and a negative anti-CCP antibodies, the score will be 0. So you need to check for rheumatoid factor and anti-CCP antibodies. Very important. So what is this rheumatoid factor and anti-CCP antibodies? Anti-CCP antibodies stands for anti-citrulinated cyclic peptide antibodies. So anti-citrulinated cyclic peptide antibodies is nothing but anti-CCP. So in rheumatoid arthritis, these rheumatoid factor and anti-CCP bodies are very, very important factor for diagnosis of the rheumatoid arthritis. So they'll be having a score of around 3. Next, you need to check for any kind of acute phase reactants. So what are these acute phase reactants? So acute phase reactants such as CRP, C-reactive protein, and ESR must be checked. If the C-reactive protein and ESR are abnormal, then there is going to be a score of 1. Okay. So the maximum score in serology is a score of 3. And joint involvement maximum score is a score of 5. Acute phase reactants, the maximum score is 1. And then you need to look for the duration. The fourth criteria is duration of symptoms. So duration of symptoms, if it is less than 6 weeks, it is 0. And if it is more than 6 weeks, it's going to be a score of around 1. It's going to be a score of 1. So totally the score should be around 10. And if at all the score is more than 6, it is the diagnosis is going to be rheumatoid arthritis. So anti-CCP bodies is one of the most specific marker for rheumatoid arthritis. Now there's another revised criteria which says that following must be noted in rheumatoid arthritis, such as, what are the symptoms? There are certain symptoms such as morning stiffness. If morning stiffness lasting for more than 1 hour is one criteria, and arthritis of 3 or more joint. Arthritis of 3 or more joints is another criteria, especially which joints? The proximal interphalangeal joint, the metacarpophalangeal joint, the wrist, the elbow, knee, ankle, metatarsophalangeal joint, all of this. But remember, there is going to be sparing of the distal interphalangeal joint. Okay, this joint will not be affected in rheumatoid arthritis. And the third criteria is it must be a symmetrical arthritis. It must be a symmetrical arthritis. And the next is very important, which is pathognomic for rheumatoid arthritis. The fourth important question is, which is pathognomic for rheumatoid arthritis? The answer to this is rheumatoid nodules. Rheumatoid nodules are pathognomic for rheumatoid arthritis. So what are these rheumatoid nodules? These are subcutaneous nodules over the bony prominences. Okay, so over the bony prominences, certain subcutaneous nodules are these rheumatoid nodules. And then you need to check for the serum rheumatoid factor and certain radiological. Then the sixth criteria is certain radiological findings such as any bony erosion or any kind of periarticular osteoporosis. So narrowing of joint space, any periarticular osteoporosis, all of this. So what do you mean by seronegative rheumatoid arthritis? Seronegative rheumatoid arthritis is generally where rheumatoid factor will be there and there is anti-CCP will be negative. So leave that. It's not that important. So now let's move on to a very important one. What are the poor prognostic factors for rheumatoid arthritis? So next topic. So what are the poor prognostic factors for rheumatoid arthritis? So there is a beautiful mnemonic here. Remember RA1. Okay, remember RA1. This is your mnemonic. So R stands for rheumatoid factor. So rheumatoid factor being positive, so the prognosis is going to be poor. Then A stands for acute phase reactants. Acute phase reactants such as C-reactive protein or elevated ESR. All of these will be a poor prognostic factor. And advanced age, of course, will be a poor prognostic factor. O for 1 year duration. If it is 1 year duration, then the prognosis is going to be poor. And N for nodules. I told you the pathognomic nodules, which is the rheumatic nodules. And then E stands for erosions. Any bony erosions in the radiological findings or ESR abnormalities or economically weak. So all these are poor prognostic factors for rheumatoid arthritis. Now moving on to the radiological features of rheumatoid arthritis. So as usual, so the radiological features, if you see the radiological features in rheumatoid arthritis, so there is going to be an evidence of soft tissue swelling and joint effusion. It's going to be a symmetrical involvement and generally juxta articular osteopenia can be seen. Osteopenia can be seen. And of course, as I already mentioned, bony erosions, narrowing of joint space, all of these will be seen. But remember, all kind of hypertrophic bony changes will be lacking. What are these hypertrophic bony changes? So sclerosis will not be there. Definitely sclerosis will not be there. Osteophytes will not be there. All this will be seen only in osteoarthritis. But in rheumatoid arthritis, all hypertrophic bony changes will be absent. No sclerosis, no osteophytes. Now I already mentioned that there is a syndrome known as Felties syndrome. So what is this Felties syndrome? So what is this Felty syndrome? Felty syndrome is nothing but, remember the mnemonic Santa. Remember the mnemonic Santa. Okay. So what is this Santa stands for? So Santa stands for, S stands for splenomegaly. Splenomegaly will be there in Felty syndrome. And A stands for anemia. N stands for neutropenia. T stands for thrombocytopenia, and A stands for arthritis, which is nothing but your rheumatoid arthritis. So this Santa mnemonic is nothing but for Felty syndrome. So these patients frequently have high titers of rheumatoid factor and subcutaneous nodules. Now moving on to the management of rheumatoid arthritis. So the management of rheumatoid arthritis is mainly going to be, first, the main steps are, you need to stop synovitis, you need to keep the joints moving, prevent any deformity, reconstruction can be done, and rehabilitate. So these are the steps of management of rheumatoid arthritis: stopping synovitis, keeping the joints moving, preventing deformity, reconstruction, and rehabilitation. So yes, so if physiotherapy exercise is very effective, so the main drug treatment is going to be NSAIDs. NSAIDs, especially such as indomethacin, is very useful. Any glucocorticoid therapy also can be done, and certain immunosuppressive drugs, immunosuppressive therapy can be given. Under immunosuppressive therapy, what are the drugs given? Leflunomide, okay, leflunomide and cyclosporine, and very importantly, we give DMARDs. What is this DMARDs? DMARDs stands for disease modifying anti-rheumatic drugs. So DMARD stands for disease modifying anti-rheumatic drugs. So the drug of choice given is methotrexate. So other drugs such as etanercept, infliximab, adalimumab, all this can be given, and even abatacept is also given in rheumatoid arthritis. So remember DMARDs, disease modifying anti-rheumatic drugs, and the drug of choice here is methotrexate. You can give other drugs like etanercept, infliximab, adalimumab, and abatacept. And what surgery will you do? So the surgery is going to be generally a reconstructive surgery, and or an open or arthroscopic synovectomy can be done. Arthroscopic synovectomy and arthroplasties and total joint replacement also can be tried. Arthroscopic synovectomy or arthroplasties can be done. So let's revise. So what all we have seen? We've seen what is rheumatoid arthritis. We've seen the various deformity, botanier deformity, swan neck deformity, windswept deformity. Also to add on, there is also going to be hammer toe. This is a very favorite MCQ. Hammer toe deformity is seen in which condition? It is seen in rheumatoid arthritis. And also another one, Z deformity is seen in which condition? That is also the answer is going to be rheumatoid arthritis. Remember, botanier deformity, hammer toe deformity, Z deformity, swan neck deformity, windswept deformity. And then we saw the classification criteria for telling it as rheumatoid arthritis, And then we saw the other criteria, the poor prognostic factors for rheumatoid arthritis. Then we saw the radiological features of rheumatoid arthritis, what is Felty's syndrome, and then we saw the management. Okay, so let's solve a question. So which deformity is going to be involving distal interphalangeal joint is going to be extended? So what is the answer? So distal interphalangeal joint will be flexed in case of swan neck deformity, but it will be extended in case of boutonniere deformity. So let's solve the next question. Rheumatoid arthritis affects which region of the spinal cord? So it's going to be cervical spine region. Cervical spine region. I hope this video was useful. So to learn more videos and to know more content regarding this channel, please do subscribe and like this channel. Thank you.